or hip symptoms, what have you. So what we're going to get into today, though, is more so how you are going to start thinking about hip impingement and how you're going to start advising your patients and doing referrals. Okay. Then we're going to go through osteonecrosis of the hip, snapping hip syndrome, which is very commonly confused. Okay. Transient osteoporosis of the hip, and trochanteric bursitis. Just to be clear, all these diagnoses we're talking about today, these are primarily going to be concerned with adult patients, okay? So patients over the age of 18, okay? We will get into some hip, knee, and lower extremity pathology this semester, and just make sure you key in when we are talking about pediatric populations, right? Because those are going to be high testable areas for PANS. You are going to see them, I promise you, okay? I promise you. All right, hip impingement. So what is it? It's also known as femoral row acetabular impingement. Okay, so it tells you everything you need to know. The femur and the acetabulum are involved, correct? So this is the area of concern in the hip. Specifically, it's that relationship in the hip joint itself, okay? So it occurs in areas of osseous deformities, okay? And like we talked about yesterday, it's important to understand that femoral head-neck junction, right? Or the acetabulum, right? So that's the cup side, and understand where the pathology is present. Can it be present in both places? Yes. But the key characteristic is that there are areas where there's abutment. Okay? Does everybody not understand what abutment is? They are making contact. Okay? Especially what? At extremes of hip motion. Are there some physical exams you guys have already learned where you put the hip in extremes of motion and test the patient and see if they have pain? Yes. Right, so the physical exam stuff is going to really play a large role when it comes to diagnosing and classifying, and characterizing hip impingement. Okay, so if you have this abutment or this friction, if you will, this repetitive contact, what's it going to cause? It's going to cause degeneration of both the labrum potentially, acetabular labrum that we discussed yesterday, and or what? The cartilage itself. Okay. If it gets significant enough, can it wear the bone down? Yes, absolutely. Okay, but that's primarily what we're talking about when we're talking about that abutment, is that it's causing this degeneration, and this is not something that is necessarily going to be due to specific trauma. It's just going to be more of a repetitive, constant activity level. So the history is going to be super important as well. And you have two different types. Okay, the cam deformity. Right? That is where we're concerned about that head-neck junction. Okay, and it's going to cause a bump. Okay, so when we get to their x-rays, I'll characterize that a little bit more. The pincer, though, that's going to be on the converse side, so that's going to be the acetabulum. Okay, so that's what we're talking about, that superior acetabulum. Okay. So I allegedly put these pictures in here, okay, to show a little bit more about what we're talking about. So we see the cam deformity, it's circled there, how you have that abnormal contour of the head-neck junction. Does everybody see that there? Okay, so that should be a nice little curve there. If you go back to your radiology slides, right, and you look, it should be a curve there. It should be a concave side. And that natural concavity is absent, okay? And the pincer side, you see how it's circled there? That's on the acetabular side, okay? And then that last picture there is a picture showing combined. So you can have one, or you can have both. One or the other, or both. Okay, so when you see combined FAI, that means they have both a cam type deformity and also pincer type deformity. Okay, so when we're talking about abutment, this is what happens to the hip when you put it into abduction and extremes of motion. Okay, going into internal rotation as well. But this is where we start seeing that abutment, that contact that's being made, and over time that can cause symptoms, right? That's an abutment of either the head-neck junction or the abutment of the acetabular side, and or the mixed type. Okay, does this picture make sense to everybody? Yeah, I thought this was a very good picture. So all the red you see there, that means that there's ongoing what? Degeneration. There's ongoing inflammation potentially, right? And so as a result of this, the patient can experience, ongoing symptoms that could feel like it's deep inside the groin. Okay, so keeping with that concept, right? When we talk about that deep pain there, right? We talk about this C sign, right? So the patient will put their hand on their hip and say it's right about here. Okay? Everybody sees that in the picture, I'm trying to represent that. So when you tell the patient, point to me where it hurts the most, if they do the C sign, then you yourself have to tell them, say, okay, but is it deep inside the joint, or is it in the groin area specifically? And what am I talking about there? So I'm talking about there is that I have gotten some referrals from providers that send me a patient with a hernia. Does Ortho treat hernias? Ew, right? So it's important for you to figure out if they have a hernia. There's a whole exam for hernias, correct? You guys are going to do those as seniors, won't you? Okay. Okay. But abdominal pain is what they're talking about, right? So we discussed yesterday how the ASIS, the anterior superior iliac spine, going down into what? Where's the area where that ends? The pubic symphysis region? Okay, that kind of makes up your inguinal line. Okay, so that's what we're talking about there. Okay? So when you ask the patient to describe their symptoms, right? Describe the quality of their symptoms, right? They may tell you that they have mechanical symptoms that is exacerbated by rotational type movements. So what are we talking about there? Could it be deep squatting? Could it be activities where they're crossing their legs? Okay, yes, things like that. Okay, so that's maybe what they describe to you. Okay, so at the bottom there I highlighted as well that mechanical symptoms can be present. Just like we talked about how somebody can have mechanical symptoms in the shoulder, right? Because the shoulder has a labrum, right? Correct? Yes, right? So they can have mechanical type symptoms. It's important for you to delineate the symptoms that the patient is experiencing. Is it that they have decreased rotational motion due to these deformities we just talked about, right? If you have this deformity here, right, where you have acetabulum and you have head and neck junction of the femur, right, and you have that overgrowth there, that bony response, right, can you have decreased range of motion? Yes. Okay, so again, it's not just that they have decreased range of motion or pain with motion, they may be experiencing mechanical symptoms as well. Does that make sense? Okay. So when we talk about our physical exams, these are going to be paramount. Okay, physical exam, when it comes to hip, you got to do a good hip exam. You got to figure out if you're dealing with this FAI, or sometimes labral pathology gets thrown in here too. Okay, so when you do a Fadir test, that is flexion, adduction, right, towards the midline, and internal rotation. That's what that is. Okay. You guys have practiced this before, correct? No? Never? Okay. You will practice it, and I will show you. Okay, and I will also show you how to do it correctly versus how most people think they're supposed to do it. Because this is a dynamic motion, correct? You're trying to actually cause that impingement and reproduce their symptoms, correct? So this is a passive motion that you're going to do. Okay, the important thing to understand here when you look at this picture is that when you're looking at the knee is going towards the midline, and the foot is going where? Out, right, away, laterally. Okay, so if you see it described, you have to be able to describe this test. I put the patient's hip flexed to 90 degrees. I flexed the knee at 90 degrees. I then adducted the entire leg, adducted and internally rotated. Does that make sense? And when I did that, the knee went inwards, medial, correct? And the foot went outwards, laterally. Does that make sense? So that's how you use your words, your big ortho words that you guys are learning, and describe this test, okay? Is it reasonable to assume that you should know how to describe this test sometime in the next couple of weeks? Yes. I think that you guys know what I mean by that now, right? Because that may be what you get. And then you'll get a result, right? And then you're looking to see, is the patient neurovascular intact? And then you're looking at the question, and then you're trying to decide what the correct answer is. We will go through this in lab in great detail, okay? Because again, this is a test that's very commonly done wrong, okay? Again, the purpose is to reproduce the symptoms. So if you're just being real gentle about it, I don't want to hurt the patient. I do want to hurt the patient, okay? I want to see what kind of pathology you have with this, okay? Because that could be the big deciding point between whether I think it's a labral tear or whether I think there's a cam pincer type deformity, or both. Make sense? And then of course you're going to get radiographs, because as we know, we always get radiographs, right? Are you ever going to refer a patient to someone like me without a radiograph?
Yes.
The answer in this case is no. You are correct, sir. Okay? So then we get into the radiographs. Okay? So you do need to be able to pick out these deformities on radiographs. You do need to be able to. Not just for my course, but for practice and PANCE. I actually saw a PANCE question allegedly, right? Allegedly, so a test compromise, where it just gave an x-ray. Didn't put an arrow, didn't put anything, okay? But you see this deformity here that's clearly marked, and I labeled it even, allegedly, right? So it says cam lesion, okay? Cam deformity, cam lesion, same thing, okay? It's also called a gun stock deformity sometimes, or pistol stock deformity. Did everybody see why? If you don't have that normal curvature here, it's an overgrowth of the bone at the head-neck junction. It makes a pistol grip looking deformity, right? Does that make sense to everybody? All right, so that's the cam deformity, okay? So of course the one on the bottom then is what? The pincer deformity. Everybody sees how if you look up here, you see a coverage of the acetabulum, but it doesn't seem to be coming out to here to where the arrow is, correct? If you move down to this picture here, you're recording over here. All right, so if you see here, right, there's the acetabulum stops there, doesn't come to the blue arrow here. If you go down here, doesn't the acetabulum seem to have more coverage of the femoral head? It does, correct? So that's what you're talking about with over coverage or an overgrowth of the acetabulum. Does everybody see that finger-like projection looking acetabular over coverage there? Anybody not see it? Okay, again, you look here, I'll do this side as well. You see the coverage here, but it doesn't come to the blue arrow. You come down to here where you have an overgrowth of the acetabulum, over coverage if you will, and you see how that the acetabulum seems to cover more of the femoral head. Will that cause impingement because you have decreased natural range of motion there? Yes, it can, correct? So that's what causes those symptoms, okay? So getting into this, right, so that's the overcoverage here, the focal overcoverage of the acetabulum, okay? As the acetabulum is doing the overcoverage. Then you have something called a crossover sign. I have seen that commonly used in questions, okay? It won't necessarily tell you to label a crossover sign, but it will tell you that the patient has a positive crossover sign, okay? I have provided this picture here, allegedly, as a supplement. This is not testable. You do not need to know how to draw this. You do not need to know how to find this, but you need to know what a crossover sign is. If you look at this picture that allegedly was provided by somebody that looks like me, it explains why you have that crossover sign, okay? So again, I labeled it clearly in red. This is just FYI. You do not need to know how to draw a crossover sign, okay? Any questions about that? Okay. So diagnostics-wise, again, you get your radiographs, you see it, all right? Maybe you do a little bit of therapy. We'll talk about treatment. Patient comes back, or you're suspecting a labral tear. Would you get an MRI? Yes, you would get an MRI, okay? If you get a CT scan, because you're worried about bony abnormalities, right, because that's the next step when you're worried about bony abnormalities from an x-ray, then you can always get those 3D reconstructions. Is that super helpful, you guys think, to get those 3D reconstructions to see a 3D mapping of the hip joint itself? It is. It can alleviate a lot of your questions about that. You can put it in a Mickey Mouse type picture where you can rotate it, and you can look at it, and you can be like, oh, that's over coverage to me. Okay, makes sense? And again, at the bottom there it says MRI arthrogram for labral tears. So arthrogram, here we go with that word again. This is a joint, correct? So they're going to inject that dye into the joint, and then they're going to do the MRI, and they're going to see what happens. Okay? If the dye leaks out, it means that there's no continuance, or there's a discontinuity in the labrum. That's how you diagnose that. Okay? All right. So I already told you guys how many people in here have labral tears. If you're 35 or above, a high percentage of you. Okay? Otherwise, I question your dedication, and I want to see your PT scores. Okay? All right, makes sense. Over time, the labrum will just degenerate. Okay? Your hip sacrifices stability for the incredible amount of range of motion that it has. Would you agree? I would. Okay. So again, you can put your hip in some positions just naturally, not without even having all these deformities or these lesions, and wear down your labrum. okay? So do not be alarmed when you get out in clinical practice if every single MRI you get of a seasoned mid-range person has a labral tear. What does that mean? It means you need to correlate your physical exam and see if that is the patient's issue. If that is not the patient's issue, then you note it and you move on. Does that make sense? Don't call me about every labral tear, because I will tell you how old is the patient, and you're going to tell me 36. I'm going to say, okay, what do you have for breakfast? Like, this is like common stuff, right? So they're active duty, they have a labral tear, good to go. Aha! Do they have mechanical symptoms on exam? Yes, sir, they do. They have snapping, clicking, popping. When I do my Fadir test, it reproduces those symptoms exactly. That's what the patient complains of. When they go into deep stooping, cross-leg activity, right? Deep squatting, cross-legged, right? Camera didn't see. Okay, so then it reproduces those symptoms as well. That makes sense, doesn't it? Good to go? Okay. I know I'm simplifying it, but trust me, you'll get out in practice and you'll try to send every single labral tear to ortho, and they're going to be like, not really much to do here until you do some conservative care. I won't talk about that. Okay? So adverse outcomes disease, so nothing is done, right? When the patient just progresses on. So can they have chronic pain? Sure. Okay. Osteoarthritis, we talked about how this is wear, right? I highlighted that in the beginning. This is progressive wear down of bone, cartilage, right? Not that order, right? Cartilage first, then bone, and or the labrum itself. Okay, so again, they can have early arthritis, and that tends to be present in people with FAI in 60 to 80% of cases. How many percent? 60 to 80% of cases. Okay, it is in bold gold, right? So it might be important to remember that. Okay. So what's the treatment for most FAI? I'll paint the classic picture. Most FAI. Let's back up real quick. When a patient presents and they're, let's say, 19 years old, straight out of boot, right? And they you ask them, because you're an astute clinician, you say, did you ever have any hip pain before boot camp? And they say no. And you say, okay, what was different about boot camp? You're just asking the question, you know what was different. They were doing mountain climbers, they were doing whatever, right? They were climbing walls. They were doing things they'd never done before, rucks, right? They were carrying heavy loads, okay? And all of a sudden they started having these symptoms, but never had these symptoms before and no history of trauma, right? So you think to yourself, okay, is FAI, like we described earlier, CAM and or pincer type, can those be congenital? In a lot of cases they are. A large percentage of the cases are congenital. Okay, so what that means is they always had this architecture of their hip, right? Either the femoral head neck or the acetabulum, but they didn't have symptoms until they started being more active. So that's the usual type patient you'll see in the younger population, so have a history or a story that goes like that. Periods of increased activity, right? Something changed, okay? As they get older though, if they have a history of FAI, can it get worse? Yes, it'll get worse, right? So then you want to know how worse it got, okay? How much worse? Thank you for correcting me. That's what he's here for. Okay, so how much worse is it now? Okay, so that's important to understand because that's really what you're going to base your treatment guidelines on, okay? How you're going to proceed forward, right? Because isn't NSAIDs, rise of female adaptation physical therapy, that's everything ortho, right? That just seems to be the answer, okay? But if you look at an x-ray and they're in their 40s, they have a history of FAI, gets better, gets worse, they continue on their career, and now it's gotten to a certain point where their x-rays look worse. Right, Lieutenant Bishop? Yes, correct, right? It looks worse because you compare it to their previous radiographs. At some point, can you just keep sending them to physical therapy? What's going to change? Nothing on the insanity meter, that's for sure, right? So that's what you need to decide. So you can't PT this to death necessarily, right? So if you do get to the point where you're like, okay, they've done the physical therapy, they're older now, seasoned, I prefer to say seasoned, right? And it just doesn't seem to be working for them anymore. You give them your little handouts from your book, right? What do you do next? then you can consider what? A fluoroscopic guided hip steroid injection, okay? You guys, I went back and looked at your course material. You know what fluoroscopy is, correct? Everybody here knows what fluoroscopy is, right? Or should, right? According to that test question that was on your test in the sophomore semester. Right. Yeah, allegedly, no, I verified. Okay, so you understand that fluoroscopy guided means that you won't be doing it in clinic, right? So you need, if you get to a point where you've done the physical therapy, activity modification, maybe they're pear-shaped. You tell them you need to lose a little weight. Okay, you've done all that stuff, right? Then you got to get to the big gun, right? You got to do fluoroscopy, right? Guided injection. When you send them to radiology, and you just say, just do a fluoroscopy guided injection, that's going to be what? Like we discussed before, both diagnostic and therapeutic, right? So you're going to be very curious to know how much pain relief the patient got after that hip injection. Does a radiologist normally document that? They do. Read the report. Patient reported. They're going to document, they're going to high-five themselves, right? They're going to document something like successful injection, right? Because they're doing a fluoroscopy guide. They can see where the needle goes. They can see where the fluid goes. They want to make sure they're in the hip joint, correct? Right? But then they should, hopefully, also document that the patient experienced relief after the injection. But that's usually where it's at. That's usually kind of where they leave it. You need to ask the patient, how much relief did you get? If it was 100% of the relief of their pain, is their pathology intra-articular? Intra-articular? Yes, that makes sense, right? If they got 0% relief, and you read the report, and the radiologist swears to God that that injection went into the hip, then it could be somewhere else. Does that make sense? And do some patients sometimes have pain elsewhere as well as having intra-articular pain? Yes, and then it becomes kind of clouded, but we'll talk about some of those conditions. But just understand that, again, you don't just send them and forget it. You want to kind of like see diagnostically how that injection did for them, okay? Should that be part of your assessment and documentation in your notes? These awesome soap notes you guys are learning to write in Clancor? Not very, they're not that awesome. Okay. But we'll get you there, okay? So if you see a patient, right, you document they have a history of FAI, and they're 24 years old, and you have done no physical therapy, and you haven't even considered an injection, you send them to surgery, do you think we're going to just do surgery on somebody, even if we can point to something on the screen in clinic and be like, there it is, there's the bump, right? Or there it is, there's the overgrowth. No, right? We will then turn around and do a diagnostic and therapeutic injection by fluoroscopy guidance, okay? Does Ortho do those in clinic? We do, just so you know. Okay, but not everywhere. I did them at the academy. Okay, they take time. Okay, and do we do a fluoroscopy guided? No, because we know what we're doing. That's me. Okay, but we will do it in fluoroscopy guidance, I guess, if it's questionable about the anatomy or something. But again, there is a technique where you don't have to do them with fluoroscopy. Usually that's reserved to people that specialize in orthopedics, right? And so what I mean by that point to that is, if for some reason radiology says, I can't do that injection for 6 months. Does that ever happen, Mr. Willey? Where you go somewhere and they say they can't see you for 6 months?
That's my experience, sir.
Yes, he is still traumatized by his experiences, right? So I would urge you to contact orthopedics and see if this is a service they offer. Does that make sense? That way you don't delay care, right? Because if somebody's like on a ramp up for a deployment, right, they can get the injection, they can roger up, take out their pack, pick up their weapon, move on, then maybe that's what you need to do, okay? So we already told you that the pelvis, right, specifically the acetabulum, can have abnormalities, right? If they have like a pincer type, and over time it can cause degeneration, as evidenced by those pictures that I provided you, allegedly. Okay, so if there's bony abnormalities in the pelvis, do you think we can take those bones and break them and change that alignment? We can. That's what that term pelvic osteotomy means. Does that make sense? Yes, sir.
Are pelvic osteotomies more successful than hip arthroscopies, even though it's more traumatic?
So then we get to it. So his question was, is pelvic osteotomies more successful than hip arthroscopy as it relates to FAI?
Yes, sir.
Okay, good. So this gets to a good point. This is a good question, sir. Thank you for asking it. When we're talking about arthritis, what did I tell you that you could do for arthritis if somebody has hip pain? It was a few weeks ago, a few months ago. Replace the hip, right? So really the question becomes, when you're talking about hip arthroscopy, right, we're going to get all that imaging. Maybe we'll get an MRI and a CT scan. Because what we're trying to figure out, is this just arthritis, or is there structural soft tissue abnormalities that we can address with just hip arthroscopy, right? So that's a big decision point. Okay, so when you go on phase 2 and you're rotating through, you'll realize that the total joint guys, maybe me a couple of years ago, excuse me, like all we care about is replacing the hip, right? Those are the patients that get sent to us, the ones with bad arthritis. They all have hip labral pathology. Does that make sense? Everything's worn down. The labrum is trashed, right? But once they get to us, we're going to just replace the hip. If you're talking about hip arthroscopy, those generally tend to be thought of more as hip preservation specialists, right? Not restoration, but preservation. So they try to do procedures in the interim to correct intra-articular pathology to hopefully, again, make the patient less symptomatic and stop the progression of some of the wear and tear. Does that make sense? So hip arthroscopy, right, is something where they put a scope, put some instruments in, and try to make corrections in that intra-articular pathology before a patient would be considered for a total hip arthroplasty. Does that make sense? Okay. So if somebody does have a cam deformity, a pincer deformity, or both, right, and they don't have significant wear yet, then it's possible they could go in there and just do shave down, right, that pincer type deformity, shave down like Glenn stock, if you will, right, address some of that acetabular side, okay, and address the labral tear, because all their pathology is early stage, not end stage, which is where we start talking about replacement. Did that answer your question?
Yes, sir.
It didn't sound like it did, but that's how I would answer it to a patient. Okay, because every patient comes to me and says, all I need is hip arthroscopy. And I look at them and say, hey, your hips are thrashed, right? Your hips are, you got older hips, okay, for such a young person. All right, so that's where you hear the term osteoarthritis advanced for age. Have you guys ever heard that term? No? Well, now you have, okay? So if it's osteoarthritis advanced for age in a younger patient, then sometimes that hip arthroscopy stuff can still be done. But as some people in this classroom know, because you keep bringing me your reports of your imaging, right? You don't get 100% pain relief. If you want to call yourself out, please feel free to do so, but you don't have to. But it's not 100% with the hip arthroscopy stuff. If we change the hip, can we control it more? Yeah, we just give you a whole new hip. Does that make sense? But everything in between is variable. So again, if you send me a patient and you tell them that ortho is going to make them 100% pain-free, Mr. Rudolph, I see you looking at me, sir. Am I going to come find you? Probably. Yes, the answer is yes. Right? Because if we can't make everybody 100% pain-free. All right, so can we improve some of the mechanical symptoms with hip arthroscopy? Plus or minus a labral repair? Maybe. Does that answer your question better?
Yes, sir.
Okay, you're just going to keep saying yes. But if I didn't answer your question, then approach me later. Okay? All right, does that make sense to everybody else? Is any of that testable? No, right? I didn't mean to pick on you. I kind of did that. Those are all good questions, right? Because again, I'm telling you right now, when it comes to hip impingement, hip pain in young people especially, you're going to spend some sleepless nights looking this stuff up and trying to figure out like, oh my God, do I send this to ortho? The short answer is do all the steps first, see if the patient has improvement. If they don't have improvement, in what time frame? What was the time frame that seems to keep coming up because we keep doing the same math, right? So we don't like to do math in public. 3 to 6 months, right? So again, if I can do it math in public real quick, you give the patient a home exercise program, they come back in 6 weeks. You put them in, they don't get better. You put them in formal physical therapy, they come back in 6 weeks. What's 6 plus 6? How many months is 12 weeks? 3 months. Okay? You guys get the same math? Okay. 66. Yeah. So 3 to 6 months. Okay, so again, you're going to note if the patient experiences improvements with any care that you give. If they don't get improvement in 3 to 6 months, do you think you might want to consider sending them for an injection if they have FAI? Yeah, that's when you start thinking about that, right? Is that a better answer? Or a better clarification then? All right, so adverse outcomes of treatment. So even though somebody gets treatment, right, what can they have? Right, so they can have NSAID risks, obviously. So when it comes to hip pain, can this be pain that sometimes be seriously affect their activity level? One of the things we talk about, work, play, and sleep. Yes. Okay. So sometimes this is an area with hip impingement that you may not be able to just get away with using Motrin. You guys learn about Mobic and Celebrex yet? And diclofenac and all kinds of stuff. That's when you got to start pulling out the bigger guns. Does that make sense? Okay. So the risks increase as you use stronger medications, correct? So this is an area where sometimes you'll see this risk increase. Does that make sense? Okay. Acetaminophen risks, okay. How many grams can we give a day?
3,000.
How big are they? Well, they're still the max.
I'm still waiting for my points back to see if I got that.
Right in there, 100,000. All right, who says 4 grams? Okay. Who says 36 to 3,800 milligrams? You're not trying hard enough? Okay. I will tell you this, right? When you start getting into those high doses of Tylenol, are you affecting anything other than increasing the risk of issues with end organs? Yes. Okay. So again, when you're talking about this, you need to understand that. And is there anything on here that says anything about narcotics? Okay? No, right? So again, that rule still applies as well. Okay? Does hydrocodone, have you guys talked about pain meds yet? Okay, hydrocodone has what? It has Tylenol in it, right? Or does it have Motrin in it? Okay, good. So when you start giving them narcotics, you also need to be aware, the more you dose it, you're increasing the risk of the acetaminophen as well, right? Is acetaminophen toxicity, if someone gets to that point, are they pretty much DED?
That's right.
That's dead, by the way. Okay. I will bag that important soft squishy organ quick. Okay, so again, don't forget that rule. Okay, don't just start being like, well, it's just narcotics. Yes, it has Tylenol in it. Okay, so again, do we give patients that are post-op hydrocodone, etc.? We do. Okay, so if somebody comes to your clinic and starts exhibiting signs of toxicity, right, you need to be aware of that, and you feel free to stop the narcotics. And you can call us, that's fine, but you got to deal with it on the spot. Does that make sense? Okay? We never make mistakes. So which nerve is affected when it comes to treatment of hip? Right? When we do arthroscopy, when we do any kind of open hip procedures? Lateral cutaneous? Okay, so that would be important to know. Right? HO, we already discussed that, right? That's where you make bone where it's not supposed to be. Okay, so HO is also a risk factor here as far as the patient developing it. It's not uncommon to see HO, heterotrophic ossification, in patients that receive treatment for hip impingement. Okay, DVT, there it is, and stiffness. Okay, so we do procedures on people in their hip and they get stiffness. Okay, if you see somebody in the clinic and they got some kind of procedure done for their hip and now they're having real stiff hips, should you be concerned? Yes, right? Because remember what's the enemy of orthopedics? Stiffness, right? So you need to identify that quickly because maybe we need to get a little bit more on their physical therapy and make sure they're doing their therapy. Can they get inflammation of the hip joint that leads to a decrease in range of motion due to that secondary effect like we did in adhesive capsulitis? Yes. Okay, so it's very similar. Okay, motion is lotion. You got to get moving. Okay. Good to go. So when should you refer? So pain refractory to non-operative treatment. So you've done the blueprint, you follow the plan, you get to a point where they're just not improving, you got to start thinking about the exit, right? Because that's what you guys think about, the exit. How do I get rid of this patient from my clinic? All right? Not yet, but you will. So it's been 3 to 6 months, good to go. Early referral in younger patients, okay? That is in bold gold. So what that means is if you are somebody who's seeing patients and you get a newly graduated soldier, airman, etc., or even a recruit if that's your duty station, right? You're dealing with recruits or trainees, and they're having significant pathology, and you get radiographs that show significant cam or pincer type deformity, or both. Should you refer them because they're younger? Absolutely. And again, that's just for a complete evaluation. So that's what that means by that. Okay. Can some people have significant enough FAI that it's disqualifying during boot camp? Yes. They can. Okay. Any questions about that? No questions about FAI? Nothing? Other than the really good question you asked. Yeah. So I think it's important to understand, once you guys have looked at this stuff, we'll go into that a little bit more, especially during test review. But I think it's important to understand the difference between FAI and just labral tears. Okay? Because while I keep telling you can have labral tears, in the setting of FAI, can you just have labral tears as well? Yes, right? So then hip arthroscopy becomes more viable, especially if they're younger. Make sense? All right. We'll start. Osteonecrosis of the hip. Osteo meaning bone, necrosis meaning death, right? So osteonecrosis of the bone, so that means that something's going on here where it's killing the bone. And what bone do you think we're talking about? The femur? Okay, the head of the femur specifically, right? So again, when you look at the blood flow of the femoral head, okay, how the blood is supplied, nutrients are supplied, right? And you look there and you say, okay, it looks very tenuous because it's not all encapsulating, right? So if there's some kind of disruption to that supply, could the head of the femur start dying? The answer is yes. Because if you have a disruption of the blood supply, that leads to avascular necrosis, and that can lead to osteonecrosis of the hip, because they're the same thing, right? So don't let that throw you off. Avascular necrosis is the same thing as osteonecrosis when it comes to the discussion about this condition, okay? Bone then cartilage collapses? Well, that makes sense, right? Right? No, that seems to be the opposite. This is not degenerative in nature, right? This is actually the bone losing the blood supply. Therefore, the bone will start to collapse first, then the cartilage. Okay, and that's an important characteristic when you start thinking about potentially radiographic findings and MRI findings, advanced imaging findings. Okay. So, can that lead to early arthritis? Yes, and specifically osteoarthritis. Okay. So, bilateral, always assess. There is a large percentage of people, right, or I would say a significant percentage of people, that if you find avascular necrosis on one side, that they could progress to avascular necrosis on the other side. What that means is it puts them at a higher risk for contralateral avascular necrosis of the femoral head. Does that make sense? And so you should always assess that. Okay, I told you yesterday in discussion about MSK radiology that whenever you're doing assessment of one hip joint, is that good enough? You should always get the other hip to compare. Okay? All right? Make sense? All right. What I didn't cover yesterday too, I think I neglected to cover this, was that when we were talking about hip x-rays, what's the difference between a hip x-ray and a pelvic x-ray? Bless you.
Pelvic has the entire pelvis.
What's the difference between a hip x-ray and a pelvis x-ray? How much of the pelvis is present in the view? I would agree with that. Okay, I would agree with that. So if you're talking about a quick study to compare both sides, then you would get a pelvic x-ray, right? Because then you're seeing both sides at once. Does that make sense? Okay. Would it be more advantageous to get bilateral hip x-rays and a pelvic x-ray? Yes. Did you guys discuss pelvic x-rays at all in your radiology studies? A little bit? Okay. So you know that pelvic x-rays, probably what you guys think about pelvic x-rays is that you really only get them at trauma, right? Right? That's what you guys think, right? Well, we get special pelvic x-rays before we do a total joint. Remember I told you the ASIS and certain other bony landmarks are important for deciding leg length, alignment, and rotation? Do you think when we replace the hip, we want you to still walk like a normal human? Right? So it's not just you just take it out and put it back in. We do a bunch of crazy angles, measurements, measure the lengths, measure how much of the components on one side have to be this length, how much the components on the other side have to be that length, right, in order for you to walk like a normal human. Okay, so again, pelvic x-rays a lot of times can be very useful for you guys, so don't forget about those. Lecture over. I'll rant over, I should say. All right, so risk factors. Do you guys have a mnemonic yet to remember the risk factors for avascular necrosis anywhere on the body? You don't? Okay, you need one before pants. I will provide you one, okay? I will provide you one. Because the list is long but distinguished, right, of the causes, right? That's a top-end reference. So, thank you. So, what's the one that's highlighted here? Alcohol abuse, right? Do young smokers drink?
No.
Never. Do they smoke on the weekends only, even though they tell you that they're not smokers?
No.
Never, right? So all the cases of osteonecrosis of the hip that I saw were in young airmen or Marines. I've never seen a soldier. Airmen and Marines, okay? And they all had a history of alcoholism, and they were all weekend smokers, right? So if you can't find any other cause, a lot of times we say, well, the patient drinks. They say they only drink 3 to 4 glasses, but we all know what the size of that glass is, right? It is a glass receptacle, I agree. Okay, I'm not judging. Okay, so again, a lot of times it gets chalked up to alcohol abuse, but do you know you need to look deep and wide for other causes? Yes, but are you pretty much dealing with healthy people in active duty? As my clinical group discovered yesterday, not necessarily. Will some of you guys be out there taking care of retirees? The answer is yes. Okay, so again, look for other causes too. This is a nice little list here. Is corticosteroid use on there? Do we give corticosteroids, chronic corticosteroids for autoimmune disease? So it's important to get a good history, isn't it? Sickle cell disease. You guys remember that question from the pathology test, right? Or whatever test it was. Everyone always complains about that question. Where the answer was sickle cell disease? No? Maybe the question changed.
What's
Okay.
that?
Anyways. All right, so clinical symptoms. So when it comes to hip pain, I told you that FAI has very specific patterns of hip pain, correct? And that they will have, usually if it's pincer type or candiformity or both, they'll have some decrease in range of motion. When it comes to osteonecrosis of the hip though, do they have that decrease in range of motion, meaning they can't go into that range of motion because of that overgrowth on either side? Or do they just have hip pain because the femoral head is dying, right? So when they bear weight on the femoral head, it causes pain, right? So again, the characteristics of this type of hip pain will usually present a little bit different. They will not tell you necessarily that they have deep groin pain. They will just tell you they have pain with any kind of walking, ambulation, right? And that pain will usually be more lateral, and it will radiate into the buttocks, okay? Does that make sense? So again, I'm trying to give you a way to study, okay? Make sense? Just like Forrest Gump. Okay. Severe pain with ischemia. So as this disease progresses, we know that ischemia, basically, when it gets to a certain point, it's irreversible, correct? So as it gets worse, their pain will get worse. Good to go? Could they have more pain towards the end of the day after they've been up, walking around, jumping, going up and down stairs? Yes. So pay attention to that. Decreased range of motion. This will be a little different depending on whether the head is collapsed or not, right? And what degree the head is collapsed. If their femoral head is completely collapsed, will they have decreased range of motion because they no longer articulate? Yes. But what they mean by decreased range of motion here is they won't want to do things. When you do your astute clinical exam, you will be able to get them to do those things, but they have pain. Make sense? So that's how this is different, okay? Progressive limp. Again, that's what it's going to be. You're going to say, how often do you have these symptoms? Say, well, I wake up in the morning, it's not so bad. I'm walking around throughout the day, and by the end of the day, I have a limp. Ooh, that sounds like it could be osteoporosis of the hip. So then you get a little concerned. Okay, let's take a break.
We'll get to it.
the last time that
They also, when you do the head neck, that's also muscular, but it's not totally muscular. Makes sense? It's very low muscular.
Yeah, that's the last one. Still got it. It's good.
I don't even know.
well, one gives you another day.
I'll take it. Yes.
Well, depending on what your GPA is, if you're like almond cardio,
Some of that's quick.
Well, the phones are here, so no. No. No, because he wants to get off.
This airport flies very frequently, but it didn't fly.
Oh, that's further. He'll go down.
Yeah.
Yeah, I want to keep it. I want early. Yeah. But I want to start leaving that. Like, get on the road after. That's why it's like.
Again, let's all
Yes.
What she has on the table is
What do you mean?
here it says parathyroid, the other one says parathyroid. Just talk pertains to she's just saying like if we kind of talked about that somehow. Anyway, we just had a separate list. Just no
Maybe just for the weekend, because
So
it's
it's all similar slides. So I heard actually stuff. This one it's gonna have you measure thyroid cancer, it's not gonna have you measure reams. And then scroll down to 3. You can have your reams and that proposal and more reams.
I don't know.
Yeah.
I didn't know if they were different shoes.
No, you can't really like differentiate. So if you only have one, then it's not MEN because MEN is multiple endocrine things going on. So if you only had like one thing going on, it's not an MEN, it's just that thing. So you have to have multiple things going on for it to be.
Sorry. What's up, gents?
What's up, yo?
So they promised me at 6 years that I would be able to pass my fiance. Like that was last year. It took me a year before I can like walk without pain, before I can really train. That's because I went twice a week. But it does feel more secure now. It's like
Do you know you remember like a cam or a thing?
I think all the topics like
Because like I work
26.
they don't like scoping because like they're like they get mixed results. Some people get like 100% relief, some people get like 10. Like I'd rather not have had to scope at all.
Part of me wouldn't want to like it because I feel like I lost. So hey, that is good. There's like $10 but it does feel like
One espresso. That's all.
yeah, like yeah, I don't know how to describe it. Always felt like I was yeah.
I remember we had talked about the first one. I can't remember how that went. I know that you said it looked like it sucked.
Yeah, after when I saw him, he said that's one thing.
At some point, they gotta stop. They're gonna stop writing a profile.
Luckily, after my surgery, I did get because I was in a fight.
I appreciate it. Thanks. So, Can't all be little boy. Yeah, sir. So, I think,
Like you said.
We'll talk about that
Oh, I'm not doing that's like,
I gotta crap 125 tonight. You're clearly cheating. So I can do my first one.
you still got past the first round?
Ready?
You're missing my slap.
Alright. You guys ready? Let's do it. No one ever says I was ready. Okay. Alright. I've looked at my lighthouse. That person seems to be with it, so we're gonna keep pressing forward. No one knows who it is, but I do. Okay, it seems fine. We'll see where we get to though, and then I'll let you guys go from there. It's not the load, but I can see a question loading in space. Here's loading. You're preparing a question. It's going to be a good one too. Okay. All right. So moving on. So we have decided now. All right. Some people have approached me, by the way, on break, and explain to me some of the stuff that like parents have. They have. You know, I do charge, by the way, for my time. And you'll get the bill at the end of the semester. But when it comes to hip pathology, I'm just telling you right now, what I heard from the story that I was told, right, was that the patient had a certain kind of pain, they got the imaging, and they decided, the provider, right, orthopedic surgeon, what have you, looked at the imaging and said, how do you function? Like, how do you not have more pain, right? So what's the point I'm trying to make there? Sometimes when you get those imaging reports, right, if you don't look at the images, for example, I recommend you do, right? Does it seem like radiologists get paid by the word? Yes. It does seem like that to me, right? Because they'll put a bunch of patients on there. All right, so you're like, there's all kinds of stuff there, right? They'll put things like query cyst in the abdomen or something crazy that they see, right? You cannot exclude. And then you're like, do I need to chase this down? But the point being that you have to correlate the patient's history and their physical exam with their radiographic and or advanced imaging findings. Does that make sense? Do we treat patients or do we treat images? Right? If you ever call me on the phone and I have to get to that point where I say that to you, it's not a good thing, right? Because when you're telling me that the patient has painless range of motion, but that they have a negative exam, and then you say, but the report says they have an anterior inferior labral tear, I'm going to ask you, it's like, well, did you put them in physical therapy? Did you consider an injection to see if it actually is intra-articular? Because it sounds like their exam is pretty benign, correct? Based on the scenario I just gave you. So you see how it's important to not just, don't just MRI everybody, because are you going to find a labral tear in most of us in this classroom? All right? Is anybody here in their 20s? 20s? Okay. All right. It might be the exception, right? But I'm just telling you, right? That's not the okay? So physical exam, osteonecrosis. All right, now we're on osteonecrosis. This is death of the femoral head, right? Avascular necrosis, okay? So when we're talking about physical exam, do you think they're going to have pretty significant pain with extremes of motion? Yes. Okay? So worse with internal rotation, okay? So what they mean by internal rotation is that when you really get, especially when you get to that terminal internal rotation, right? Everybody knows what I mean by terminal. You're really up in there, as my clinical director used to say, get up in there, right? You really get up in there, then they have pain, right? Versus they can't get there because they have a mechanical block, because they have a big cam deformity. That could lead you in a different direction, correct? So we would agree that when you, and we know this, right? Because you guys know that there's an obturator sign and a psoas sign for abdominal pain as well. So we understand that when things get angry and upset, right, and we put them at stress, that it can cause pain. So that's where we get this pain with the straight leg raise, right? Where is the pain? That becomes the question. Because you can't just say positive straight leg raise, because can it be positive also for lower back pain? So you're telling me nothing, right? You're telling me nothing. It's a positive straight leg raise because it reproduces their anterior hip pain, or their anterior hip pain that radiates to the lateral aspect and their buttocks. Does that make sense? So that's a better way of saying that. Make sense? Okay. Antalgic gait, we understand what antalgic gait is, right? It hurts, so they walk weird. They walk different, okay? So antalgic gait. So when we get into antalgic gaits, you guys have decided already that, you know, when you're studying for your neuro exam, trying to prep for that, right? Get ready for your OSCEs, that there's all kinds of antalgic gaits, right? So some of them are neurological in nature, but this one is not, correct? This is an antalgic gait because the femoral head is collapsing and the patient is having pain. Okay, makes sense? So when they walk, they could have a short stance phase. Okay, does everybody know the stages of walking? Have you guys memorized that yet? No? Okay. So the stance phase is only one phase of walking. Okay? So that's where that term comes from. Okay? I'm not going to go through it right now because it's not testable. But if you want to know a little bit more about when patients have pain and how it can help you to delineate at certain pathologies, then you get into studying more about the normal phases of walking. Does that make sense? Okay. And that'll become relevant later, right? So, but when we talk about short stance phase, that means they don't want to bear axial load on the femoral head. So therefore, they're not in the stance phase. This is stance, by the way. You're standing. You're in this stance, right? They don't want to be in this, right? So they'll often try to get out of it, right? So when they walk, they'll kind of lean, right? They won't want to be in this stance phase. They'll want to get out of it. So they won't be in that phase of walking for very long. Make sense? Okay? So it's not quite a stumbling gait. It's called a Trendelenburg gait. Every semester, people want me to demonstrate a Trendelenburg gait. Okay? I'll do it in the lab, fine. But I'm just telling you right now, when it comes to Trendelenburg gait, right, that's basically, I had one student say it's the pimp walk. I've seen different pimps, and they walk different ways. So maybe that's not the way to remember it. But the Trendelenburg gait, do we know what a Trendelenburg sign is versus a Trendelenburg test? Okay, so we would agree that the hips are dropping, correct? I'm almost doing it, right? So they're going to do something like this, right? And they're going to try to lean forward because they'll be in that short stance phase. So it'll be something like, okay, that's enough. But I'm just telling you, Trendelenburg gait is very, very different than other pimp walks, if you will. Okay? So it's a very specific. The hips are actually dropping. Okay? Makes sense? Okay? Because over time, are they going to want to spend less time in the stance phase? Are they going to walk different? So therefore, we know this already, that in Trendelenburg sign, when we do the Trendelenburg test, that denotes that they have gluteus minimus and medius weakness, correct? So those musculature is going to get weak because they're going to walk different. They're not going to want to put as much force in that area, and therefore the muscles are going to weaken. Okay? Does that make sense? Okay, so that's how you get to that Trendelenburg gait. So as this picture astutely summarizes, it is an inadequacy of pelvic stability. Okay? So the pelvis has now become unstable due to that weakness. Make sense? So that's a natural protective thing that you'll see. Okay? Make sense? All right. The one thing that I will test you on, there's always one thing every block, right? There's one subject, and I'm like, you really need to know this because I could ask you this so many different ways, and you could get it wrong depending on how I ask it. This is one of them. Trendelenburg test, Trendelenburg sign, Trendelenburg gait. You got to know the ins and outs of this. Now, I will highlight this more as we go on. Okay? Is this the only condition you can see Trendelenburg gait in? The answer is no. Okay? So again, this is just part of the differential diagnosis that you are gathering as I have to and moving on to phase 2. Okay? So we mentioned that there's a collapse of the femoral head if that avascular condition continues, right? That state. Okay? So therefore, does it make sense that the femoral head over time, if you start giving it blood, that it will die and therefore collapse? Yes. So that's what we're talking about. Okay? You see this radiograph here? That looks like a light bulb, correct? This looks like a light bulb, correct? Light bulb, right? See this concavity? That's normal, right? That's not a canal deformity. There's a nice concave area there. Okay? So when you look there, that looks nice and round there. It doesn't look like there's any kind of collapse of the femoral head. Okay? So if you start seeing collapse in the femoral head, let's think about this, right? Does that mean that the disease process has been there for a day or two, or maybe a couple of weeks or a couple of months? Months, weeks, a longer period of time. So it's more chronic, okay? So again, you could potentially get radiographs, right, because you always will, and they're completely normal, right? But your suspicion needs to be based on your physical exam and the patient's reported symptoms, right? So that's what it's getting at when it says normal early in disease, okay? Crescent sign, that is a sign that you'll see on, bless you, you're welcome, sir. You can see both on radiographs and you can see on MRI, okay? It's basically just an area, everybody knows what a croissant is, right? Versus a crescent, okay, not the same thing, right? I was thinking about croissant earlier right now. Okay, so a crescent sign is basically just that half moon appearance that you see there. Okay, so that's what. So what that is, by definition, is a subchondral fracture. Right? Remember, it's dying from the inside out. Correct? Right. So you have a collapse of the subchondral region. Okay, so that's a subchondral fracture by definition. Good to go? Okay. So if you see it on a radiograph, the crescent sign, okay, that means it's late disease. You got to get advanced imaging faster, okay? Then you're going to get the MRI because that is what? Confirmatory. It's in bold gold. You know that there's a difference between most common test done versus the best test done, correct? So this is the test you want to get to confirm your suspicions or confirm the pathology. But I'll go a little bit further with that. So when we talk about this collapse, is there a classification system that we grade the collapse on based on findings on advanced imaging? Yes. So this is also used for further classification, for further characterization as well. All right, but for purposes of testing, remember confirmatory test. And then the question becomes, is it bilateral? If you order a right hip MRI, are they going to automatically do a left hip MRI? No, you need to order it. Does that make sense? Okay. So if you're concerned about the other side, because we talked about how there can be an incident, a high level of incidence, right? Between one side and then progressing to the other side, right? Then you need to make sure that you're adequately assessing the patient by getting enough bilateral hips. Okay, good to go? All right, so this is what we're talking about. This here is not testable, okay? Not testable, right? But every semester I've gotten a question about it, so allegedly I added a little picture there just to show you, if it progresses long enough, right, it can be pretty bad, right? Because will the head just completely collapse to the point where the femoral neck will decide to fracture? Yes, okay, it will. Okay, so it's not just a collapse of the femoral head, it can lead to a fracture of the femoral head neck, and then et cetera, et cetera. Make sense? So you need to catch this early. You think that's what I'm saying? Yes, I'm saying you need to catch it early. Because if you catch it early and they have smaller lesions, then do you think it's reasonable to make them non-weight bearing? 100% non-weight bearing on crutches and continue to follow them out and see if they improve? Yes, that's reasonable. Okay? Is this infection? No, not necessarily. Can it be due to infection? It could. But this isn't necessarily infection. Right? So there's a chance if it's not infection, it's due to some other process, it may improve. But if you have larger lesions, what they're getting at here is that you can have secondary osteoarthritis. So what does that mean? So that means if they got to a point where the lesions got larger and then either regressed, right, or was successfully treated, can they still go on to have osteoarthritis? The answer is yes. Okay. You see this here? Does that look like there's a nice space? Remember how we talked about loss, right? Loss is that a decrease in the joint space, correct? That's part of loss. Okay. Does that look like the femoral head is right up on the acetabulum? It does. So you have a complete loss of that space. Okay, so that's what you can get even with early treatment of osteonecrosis of the hip. It's unfortunate, but again, certain patient populations will go on to still have this radiographic presentation even after treatment. Okay, so what kind of symptoms, conditions, did we talk about? A lot of you hate you, right? Who hates you in autoimmune disease? You, right? So again, even if you treat this condition specifically, you still gotta treat the underlying, systemic disease, okay? Enough on that. All right, so that's where that term protected weight bearing comes from, okay? Protected weight bearing means you are going to tell the patient initially that they are to be non-weight bearing. No weight bearing whatsoever. No weight bearing whatsoever. And then over time, you're going to advance their weight bearing in a protected manner. Does that make sense? So what does that mean? Has anybody heard the term 15% weight bearing for the first week? Then progress to 20% in the second week? Then progress to 25% in the third week? Okay? Yes, that's what I'm talking about. So you can have an advancement based on the patient's symptoms and their radiographic improvement. Okay? Are you going to be doing that? No. That'll be something that's going to be between physical therapy and orthopedics. Right? We're going to tell physical therapists at week 4, if they're not having this much pain, they can go to 50% weight bearing. Does that make sense? So that's what we're talking about when we talk about protected weight bearing. Is that confusing for you? No? All you heard was it won't be me, and therefore I don't need to remember this, right? Okay, but just remember protected weight bearing. So what is the thing I want you to remember? If you have somebody come to clinic, Mr. Griffin, okay, and you're concerned about osteonecrosis of the hip, you're doing a bunch of testing and they're having significant pain that gets worse towards the end of the day, do you think that that's a good time to hand them a pair of crutches and say, I want you to use these and be completely non-weight bearing until we figure this out? That's what I want you to remember. Okay, because that's something you can do early on to make sure that the right steps are taken. Okay? Make sense? And there's a bunch of conditions that I will talk to you about this far where that's what you need to do. Okay? Operative, the world is our oyster. Right? Again, we're going to get all that advanced imaging and we're going to stage it. And based on the staging and the patient presentation and the length of symptoms and their other comorbidities, that's how we're going to treat them. What is that? That is a lot of different things. Okay, so it's not fair to go through that because I definitely won't let you go early that way. Okay, so but not total hip arthroplasty. Okay, that 24-year-old I told you about, she had a total hip at 23 years old by the time I met her. Okay, 23-year-old young airman with a total hip arthroplasty. I told her you can never run again. Okay, you think she's running? She's freaking 24. Well, now she's 29 years old, right? But she's still going to keep running, right? So, but that's the thing. It's supposed to change her lives, right? So we try to prevent that. But once that head collapses, can we regrow a bone in the lab yet? Only in mice. Okay. So maybe our only choice is, like I told you before, we can control the environment by controlling the environment. We just give them a whole new hip, but that will change their life. Make sense? Okay. She went to rehab. She's still on active duty, I think. Right. You see this big screw here, right? That's partially threaded, cannulated screw. You don't need to know that. Okay. But if we said that this could lead to instability, right? If the femoral head is collapsing. So do you think that firing a big screw in there to provide that stability can cause it, while it's healing, can cause it to have more stability? Yes, but that doesn't mean it can be 100% weight bearing right away. So again, not every treatment's going to have the same kind of follow-up. So it's important if you guys are seeing these patients in clinic that they're adhering to their ortho follow-ups and their physical therapy protocol. That's it. Okay? Any questions about that? Okay. What happens if we treat them and what could happen? Excuse me, if we treat them, well, they can still get a femur fracture, right? Especially if they're non-compliant with their protected weight bearing. Okay, that's bad. Correct? Okay. If they come to your clinic for a follow-up and they're not on crutches and they're supposed to be, you tell them, you have running the risk of a femur fracture if you don't do what they tell you. Okay? Now you know what to say. Okay. Prosthetic loosening after arthroplasty. So we put the prosthetic in there, as you can see here, right? The acetabulum has that cup there. That's new, right? Then you have a new femoral head and a stem, as it's called. That's that portion that goes into the femur itself. Okay, but can all that loosen up if they're doing too much activity too soon? Yes. So again, that puts it at risk. Okay. And let's talk about this real quick. Does it seem like these screws here, right? These are fully threaded cannulated screws. You don't need to know that. Okay. But does it seem like those screws are going through that tenuous, in and around that tenuous blood supply that we already talked about? It is. So there's a technique to this, right, where you try to do it in a certain way, but it's not without risk of actually causing further risk for an avascular state, even after you fire those screws. Does that make sense? So this could still happen. Okay. So, all right. Any questions about that? Do we have to go in there and take these screws out? Because that's what it's showing, right? We don't. Okay, but do you think, is that the greater trochanter there? Yes, that is. Okay. So could they potentially have some rubbing in that area because that screw head is prominent? Maybe, right? So sometimes we go in there and take those out. Okay. We'll talk about trochanteric bursitis later. Okay. Referral decisions, red flags, you see it. If you see it, it needs to see me. Does that make sense? This is not something you're going to stay and play with. Okay. You're going to send it and make sure that you make the patient with blood. Non-weight bearing until seen. Make sense? Okay. Clinical suspicion, even if you don't see it for whatever reason, but you suspect it, you send it. So what's the bottom line with this? Send it. Okay. Osteonecrosis of the hip can have long-term repercussions if not treated early and appropriately. Okay. Do you guys see the bilateral AVN of the hip in that picture there?
Yeah.
You guys see the collapse? Does it seem like it's worse on one side than the other? So it seems reasonable that it started on the right, correct? And it progressed to the left. Would you agree? Can you see that subchondral sclerosis here, that white thickening there? Okay, we know how to use these words now, right? The subchondral sclerosis. Does that kind of look like a crescent sign right there? Like a half moon right there? Kind of does, right? Maybe not best seen on this view. Maybe you get a different view and it looks more like a half crescent, right? But that could be a half crescent sign there, okay? There we go. All right. Any questions about osteonecrosis of the hip? Okay. Yes, sir.
So for the non-weight bearing stuff, it's obviously going to prolong or extend the life just by reducing the resistance. So we just move it to
It did, okay, so his good question. So what he said was if the patient sustains avascular necrosis of the hip, right, are we just basically waiting for the revascularization, right? What was the term you used? It sounded better. Angiogenesis. Okay, wow. That's a big word. He gets the gold star for today. Okay, so are you waiting on that? Okay, well, let's talk about this. If it's due to alcoholic intake, right, and you cut down the alcoholic intake over the time, it could potentially get better. But if it's due to an autoimmune disease, if you don't treat the autoimmune disease, will it necessarily get better? No. So then it gets back, yes, I agree with you, sir. So the answer, he said, not if you don't treat the cause. So I agree with that. So does every patient that has osteonecrosis of the hip have a predictable recovery period? No. Okay, so I will tell you this, right? This is not testable, it's not on the slides, but it'll help you understand. This is not a one-for-one thing, right? Okay? Just because they have 1 month of this kind of pain doesn't mean it'll take 1 month to improve, right? Remember I told you when you get x-rays and you're looking for changes, if you get x-rays sooner than 4 to 6 weeks, it may not show you anything, right? So do you think we're going to follow these patients out for 6 months to a year to maybe 2 years? Yes. That's usually the course of this. And even after we see the improvement, we want to make sure that nothing recurs, correct? So we might tell the patient, well, you're at the 1 year mark. I'm using an example, right? You have the 1 year mark from treatment, but I want to see you back up for one final x-ray 1 year from today to document that we're not having any issues. Does that make sense? And that's with the understanding that we're treating whatever the underlying cause is as things are going. Right? Say they relapse, right? Start drinking alcohol again. Nobody does that, right? So, or they go back on chronic steroids. Do they have a higher risk of redevelopment of AVN of the hip? They do. Okay, so again, it's not without risk. Does that answer your question? Probably too much, right? So I'm going to get in. I think we should go. Okay. So, but the reason I'm saying I went through hip impingement today versus osteonecrosis, right, in quite a lot of detail is because I introduced a lot of physical exam stuff with you guys, and I want to make sure you understand that when it comes to physical exam stuff, the only way you're going to understand whether or not you're dealing with FAI only, FAI with labral pathology, right, if they have a history of trauma, femoral neck fracture, versus osteonecrosis of the hip is to do what? Examine them, touch the patient appropriately, please. Okay? Examine the patient and get the right imaging. Does that make sense? Because we don't come back to this stuff again until we talk about pediatrics. But pediatrics is a whole separate thing. Okay, and we'll talk about that. So I want to make sure you guys understand that, you know, after you clear the next test, okay, you need to start looking at this stuff. And if you have any questions about this hip impingement versus hip labral tear versus osteonecrosis of the hip, you got to get to it sooner. If you wait a few weeks to try to do it after I start talking about the pediatric conditions, it may be a big muddled cloud, right? Some of y'all live in that zone, right? But I'm just saying, it may be a real big muddled cloud where you're not able to discern that. Right? You're like, it all sounds like the same thing. Does that make sense? Okay. Any questions about the review we did yesterday? Because I call it a review, right? On anatomy and musculoskeletal radiology. No, you just want to go. Okay. I will allow that. Have a good afternoon.